Hi, everybody. I hope you all can hear me. I believe the little icon's moving next to my name. So let's see here. I'm going to close the polling, if okay, and then change presentation. All right. So moving on to a literature review. So the main point of this is just kind of highlight a few recent articles from the JOCI. So the first article I wanted to present was the neonatal levels of TRECs in patients with 22q11 deletion syndrome and later disease features. So in this study, the authors tried to correlate the neonatal TREC levels in these 22q11.2 George patients to having other clinical features later in life. So they looked at 46 patients and compared them to 10 controls, and they used the dry blood spot cards from Norway's National Biobank. And what they did is they actually categorized the TRECs according to the number of TRECs in different quartiles. So with quartile 1 being the lowest numbers of TRECs versus quartile 4, which had the highest. So if you look at the paper, it goes from like 0 to 70, 71, 30, and so on and so forth. And they found the median TREC numbers in the 22q11 patients was around 135. So in terms of correlation between TRECs and clinical features, they found that there was no correlation with TRECs in terms of the number of infections that these patients had, hospitalizations, or antibiotic use, nor did the presence of hypocalcemia, the extent of the clot pellet, or the polyhydramnios, nor was the size of the chromosomal deletion associated with the TREC levels. On the other hand, the patients that seemed to have a smaller thymic size, as sort of to be expected, seemed to correlate with having the lower TRECs, or being the lower quartile. And while a lot of the patients did have, in general, about 40% of the patients actually had very low CD3 T cell numbers, it seemed that the patients that had the lower CD4 and CD8 T cells seemed to be the patients who had the lower TREC, neonatal TRECs at the beginning. However, there was no correlation with the B and NK cells, nor was there any correlation between the TREC levels and immunoglobulin levels later in life. Interesting what the authors point out is that the patients that seem to have the most severe or the most complex cardiac defects seem to have the TRECs in the lowest quartile. Why that is a little unclear. They postulate maybe there is TBX1 expression in the cardiac tissue, and perhaps since that could be mutated in the cardiac tissue, could that lead to the more severe cardiac defects? It's unclear. Or could this be associated with the embryogenesis, having smaller thymic, like because in the same arch as the thymus, so perhaps having thymic abnormalities, more thymic abnormalities associated with more cardiac abnormalities. It's unclear. However, in the bottom line is that the authors suggest that the neonatal TREC levels may help to guide clinical prognosis in these the George patients, and especially may help with the cardiac prognosis of these patients. So the next paper I wanted to highlight was Somatic Mosaicism for an NRAS mutation associated with disparate clinical features in a RAS-associated leukoproliferative disease, which I'm going to say RAL for short. So RAL is associated with mutations in the RAS-mediated signaling, and these patients tend to have ALPS-like features, including splenomegaly, lymphadenopathy, and as well as autoimmunity. However, these patients do have a normal fast-dependent signaling as well as normal alpha-beta double negative T cells. Of note, these the authors also mentioned that mutations in RAS are also seen in a leukemia called juvenile myelomonocytic leukemia, or JMML for short. So in this paper, they actually discussed two different patients. The first patient had a very ALPS-like phenotype with fevers, hepatosplenomegaly, pancytopenia, liver dysfunction, and she was actually diagnosed with HLH and was noted to have increased double negative T cells. However, she did not have a mutation in any of the ALPS-related genes. The second patient had a similar phenotype with the fevers, lymphadenopathy, hepatosplenomegaly, cytopenias, however, actually had a leukocytosis and a monocytosis, as opposed to the first patient actually had a normal number of double negative T cells. In addition, interestingly, she also had multiple autoantibodies, and this patient was diagnosed actually with JMML, and because of the presence of the autoantibodies, also concurrent RALD. Both patients, even though they had a different presentation, different phenotype, they actually turned out to have the same G13D mutation in NRAS, which is a gain-of-function mutation that was noted to be most expressed in the hematopoietic cells in both the patients. However, in the nails, hair, and buccal mucosa, there seemed to be less expression of this abnormal NRAS mutation. In this paper, the bottom line, the author suggests that perhaps mutations in RAS should be considered in patients who have atypical ALPS, or patients who look like ALPS but don't have no mutations in the ALPS-related genes, or patients who have JMML with autoimmunity, which both of them have overlapping but distinct features. And they propose that perhaps the fact that there's variable expression in the somatic tissue that could account for the fact that these patients have slightly varying phenotypes. So the next paper
Joyce,
I wanted to highlight.
Joyce, can I break in? I think these somatic mutations are so important. We have a very limited way to make the diagnosis of somatic mutations, but they've now been described as associated with phenotypes in Hyper-IgE syndrome and certainly ALPS, and now the RALD syndromes. I think there's a couple more as well due to somatic mutations. And I think we're just not very advanced in terms of detecting those because you often won't get them from total DNA. So I think this paper is important because it's a disease that we probably miss sometimes. But I also think it's just the tip of the iceberg in terms of looking for somatic mutations in a very general way.
I agree, Kate. I think I would also primarily look at the hematopoietic cells. I wouldn't think to look at other somatic tissues for expression, and thinking like that perhaps could alter the clinical phenotype of these patients. And actually, I think there might be one other paper. I think the last paper may have some comment on somatic expression as well, too, mosaicism as well. So the next paper, this is a, paper coming out of Seattle. So it's successful haploidentical donor stem cell transplant and restoration of STAT3 function in an adolescent with autosomal dominant Hyper-IgE. So they transplanted this 14-year-old girl who had many classic symptoms for autosomal dominant Hyper-IgE. She had a no mutation in STAT3. Of note, she had significant lung disease as well as really severe scoliosis, as well as autoimmune hemolytic anemia, which is not that common actually in autosomal dominant Hyper-IgE syndrome, but she was noted to have that. Of interest, she did not have a history of malignancy. So in this patient, she actually received a T-cell depleted haploidentical stem cell transplant from her father, so she had a match of 5 out of 8 after a reduced intensity conditioning, as opposed to, I think, prior autosomal dominant Hyper-IgE patients actually were underwent myeloablative conditioning, whereas she underwent reduced conditioning. She was treated with one infusion of donor lymphocytes for some decreased chimerism about 1 month post-transplant. However, has been able to maintain her chimerism since then. She didn't have any obvious GVHD. She unfortunately did have some reactivation of her CMV after transplant, which was treated with ganciclovir, and she did have a reactivation of EBV afterwards, which was treated with 1 course of rituximab. And in terms of her immunologic and clinical course, up to 42 months post-transplant that was reported in this paper, she was, as I mentioned, she was able to maintain over 95% donor chimeras in multiple cell lines. She actually had a normalization of her STAT3 phosphorylation and an increase in her Th17 cells. Her immunoglobulin levels normalized, and her IG levels actually dropped to normal levels as well, too. She managed to have only a few class-switched memory B cells, but they were actually able to detect some protective specific antibodies in this patient, which I think perhaps may be due to the donor memory. It's not clear. However, what was good for this patient is that she did have decreased bacterial infections as well as decreased eczema. Her nasal intra-alar distance actually decreased, and she didn't have any recurrence of her autoimmune hemolytic anemia. Unfortunately, there was no improvement in her lung disease or scoliosis, so that's one part that's the negative of the transplant. However, the case generally demonstrates that you can get successful clinical and immunologic improvement in the autosomal dominant Hyper-IgE patients after transplantation. So it just adds to our knowledge in terms of transplanting these patients. And finally, the last paper I wanted to highlight was the symptomatic males and female carriers in a large Caucasian kindred with ZIAP deficiency. So XIP regulates NOD2 activation. So therefore, a deficiency in XIP would impair NOD2 signaling, which has been associated with the development of inflammatory bowel disease as well as erythema nodosum in the XLP patients. It's noted that X inactivation, since this is an X-linked disease, X inactivation in females would lead to more preferential expression of the wild-type XIP, which has a survival advantage over the mutated XIP. So in this paper, they examined the female carriers in this family. So the index patient was a little boy who had failure to thrive, diarrhea, Crohn's disease, arthritis, erythema nodosum, and did have a nonsense mutation in BIRC4. Of the female carriers, there were 11 of them that were assessed. They were assessed for XIP expression, as well as mutations in the BRC4 gene, as well as monocyte-mediated TNF-alpha production. 4 of the carriers were noted to actually have preferential expression of the wild-type gene. So in these patients, they actually had a normal TNF-alpha response to monocyte stimulation and generally had very mild GI symptoms. On the other hand, 5 of the 7 other carriers actually had variable decreased TNF-alpha response or secretion to monocyte stimulation, and these carriers actually had a history of more severe recurring GI symptoms and erythema nodosum. And of interest, the most severely affected carrier actually had random X inactivation to the point that 42% of her leukocytes actually had abnormal expression, and there was an impaired NOD2 signaling noticed in vitro. So they propose that females who come from a large family history or strong family history or have a strong background of inflammatory bowel disease or erythema nodosum in the family, they may actually have altered XIP expression, and perhaps they should have their XIP protein checked for mutations. And it suggests that perhaps there could be random X inactivation, which may result in decreased XIP and therefore abnormal NOD2 signaling in the female carriers, which may explain their symptoms. And however, there is really a need to determine whether the degree of the NOD2 inactivation and the residual function is directly associated with the disease severity. So that is it for the literature review.
Cool papers all, really great. I'm going to queue up the first presenter. That's Palmira Delgado, and she's from Mexico City. And as I said, Dutton Vasconcelos from Brazil will be moderating this and helping us helping us to think our way through this. It's a really fascinating case. You're going to have to really put on your thinking caps. And while we're just getting everyone organized for this presentation, I want to remind you that this is put on by CIS, the Clinical Immunology Society. All trainees get free membership, and if you're within a couple years of your training, you get a very discounted membership. So if you're not a member, I would strongly encourage you. There's lots of benefits, and we hope to have a really strong and vibrant community for all the immunologists in a way that we can all get together. So with that little pep talk, I'm going to turn it over to Palmira. I don't know if we only have a certain number of microphones. I think that Saul Reyes is going to assist Palmira in the presentation. Jesse, can we open a microphone for Saul as well?
I can do that, sure.
Okay. So with that, I'm going to turn it over to Palmira, and I met Palmira about a year ago, and I know you're in for a great case presentation.
Hello? You hear me?
Go ahead, Palmira. We can hear you.
Okay, great. Good evening, everybody. I'm Palmira. I'm currently in the Fellowship on Primary Immunodeficiencies at the National Institute of Pediatrics here in Mexico City. I'm very happy to present tonight. The case I am about to present is about a male patient who was born to non-consanguineal parents from a small rural town in central Mexico. One maternal uncle died at the age of 3 of unknown cause. A 2-year-old brother is healthy, and there is no other relevant family history. He was born preterm at 35 weeks with a weight of 2.4 kilograms and an APGAR score of 5 and 7. He received no vaccinations at birth. Due to respiratory distress, extensive edema, and multiple ecchymosis, he was intubated, placed on mechanical ventilation, and referred to another hospital. A dual intravenous antibiotic regimen was started for suspected pneumonia and sepsis. Neutropenia, lymphopenia, and also thrombocytopenia were documented, which along with the poor clinical evolution led to suspect of primary immunodeficiency. The patient was referred to our hospital at the age of 3 months. On physical examination, he was found to have prominent superficial veins in trunk and limbs, with bilateral rails and right basal hypoventilation, a loud parasternal systolic murmur, hepatomegaly, and bilateral cryptorchidism, and also hydrocele. In the laboratory workup, showed profound neutropenia, mild lymphopenia, and hypogammaglobulinemia with normal B cells. Also, we have the neutrophils, the IgE, and HIV was ruled out. Pulmonary arterial hypertension was observed in the echocardiogram with a pressure of 58 and foramen oval with bidirectional shunt. A renal ultrasound was performed with report bilateral hydronephrosis grades 1 and 3. We also detected velopalaral incompetence, pyloric hypertrophy, and gastroesophageal reflux. And bilateral hearing loss too were documented. Up to now, would anybody like to share a diagnosis impression? We have the chat here.
Mira, well, people are putting in their comments.
Okay.
And can you go back to the slide?
Yeah. Yeah, I can read it. Yeah. Right. G6BC3. Yes. Yes, so this is a list of problems found in the case. A male infant with immunological disorder with profound neutropenia and mild lymphopenia and transient thrombocytopenia. Congenital heart disease with atrial septal defect and pulmonary arterial hypertension were detected. Genitourinary disease with renal bilateral hydronephrosis and bilateral cryptorchidism. Gastroesophageal disease we also documented as we talk. Prominent superficial venous pattern visible in trunks and growth retardation. So these findings were suggestive, of course, of G6BC3 deficiency. So the mutational analysis was performed through PCR and automated gene sequencing at the Research Center for Molecular Medicine of Austrian Academy of Sciences, where they found a single nucleotide deletion in exon 1, resulting in a frame shift and premature stop codon, which predicts a non-functional truncated protein. So we have a final diagnosis of severe congenital neutropenia type 4, or G6BC3 deficiency. Regarding to the evolution of our patient, he was kept hospitalized for several months with multiple infectious events requiring broad-spectrum antibiotics. To treat the anatomofunctional findings, a Nissen duplication, a gastrostomy, and pyloromyotomy were performed. As for the treatment, he received intravenous immunoglobulin replacement therapy from the beginning, as well as human recombinant granulocyte colony stimulating factor, requiring doses up to 22 micrograms per kilogram. Due to the early age of presentation, severe clinical evolution, infections, complications, and the need for increasingly high doses of filgrastim, we decided to perform an umbilical cord blood-derived hematopoietic stem cell transplantation. Conditioning regimen was busulfan, cyclophosphamide, and anti-thymocyte globulin. Unfortunately, the patient died on day 26 post-transplant. due to neutropenic colitis and pulmonary hemorrhage at 1 years of age. So G6PC3 is a deficiency, is an autosomal recessive severe congenital neutropenia. Our patient had an earlier, more severe presentation and was originally suspected to have a severe combined immunodeficiency. The lack of response of filgrastim made us decide to attempt a stem cell transplantation, but he didn't survive.
Palmira?
Yes?
This is, thank you so much. Can you go back to the laboratory slide?
Yes. Yeah, of course. Here.
Newton, did you want to comment on the case?
Yeah, I'd like to know about the platelets. Are the platelets so low or no?
Yeah.
Yeah?
No, it was 370.
Okay.
Yeah.
Okay.
Hello?
So
yes,
it's very interesting. Sorry. Yep.
When he was newly born, the platelets were low. He received several platelet transfusions in the first hospital where he was first treated.
Okay. And
they were in the range of 50,000 to 150,000, I believe.
Okay, low to low normal. Okay, perfect. And the response to GCSF was really low, isn't it?
Yeah, at first, the first several doses, the response was spectacular, but then he required more and more filgrastim as the months went by. Another thing is that the neutropenia was often followed infectious episodes, which has also been described in this patient.
Okay. And another interesting signal of this patient is a cryptorchidria, isn't it? That is associated to G6PC3 deficiency.
Right. What we hadn't read about was the hydronephrosis. But yes, several patients have been reported to have either urachal fistulations or cryptorchidism.
Okay, this patient didn't. Oh, sorry, Kate.
No, I was just going to make the point that when you have a neutropenic patient, you want to pay attention to the other clues. There are several types of congenital neutropenia where there's neutropenia and that's the only finding, but often the diagnosis will be suggested by other features like death, or in this case, the vasculature and the cryptorchidism. So sometimes it's the non-hematopoietic things that will give you a clue to the diagnosis.
Yeah, certainly. There are other cases, other causes of neutropenia that are associated to deafness or other symptoms that are really important. Maybe mental retardation that could be associated also to G6PC3 deficiency. In this case, due to the fact that the patient is a male, it's important to think about the X-linked neutropenia due to mutations in RAS too. But the other features like cryptorchidria or the abnormally seen veins, the veins really easily to see in the skin leads to the diagnosis of G6PC3, and also the deafness.
I think Luis has made a really interesting observation. He suggested reticular dysgenesis, which I think if these labs were all that I knew about the patient would probably be number one on my list. The combination of deafness and low neutrophils, low lymphocytes, very suggestive of reticular dysgenesis. So I didn't want that to pass by. Very insightful comment from Luis. Thank you. And I think Avni's comment has sort of gone past where we can see. Avni made the point that this IgG is maybe not so low. How old was the patient, Palmira, when this IgG was obtained? Was this 3 months?
3 months, yes.
So that's the physiologic nadir. So 398 is not very bad for 3 months of age.
No, not really.
Yeah.
Yeah, well, he was sent to our hospital as a probable SID. And the thing that interested me was that he had both neutropenia and lowish IgG. And then all these transient variable cytopenias, the skin, and the initial good response to filgrastim. I thought for a moment of WIN, and this is how we started to read about G6PC3 and the bone marrow findings that we should encounter. But it was a difficult diagnostic challenge, I believe.
I can see why. I think the neutropenia cases are always pretty hard. I'm going to try, there's a notes function, and I'm going to try and put a little table that I've made comparing different types of congenital neutropenia. I'm not totally sure it's going to work, but let me, I can.
Sorry?
Newton, do you have any additional comments about congenital neutropenia?
I think that that's important to rule out VPS45 deficiency due to the low response to GCSF, but the disease is different. I think that the case is very typical of G6PC3 deficiency, and it's a very, very interesting case of agranulocytosis of congenital neutropenia. Really interesting.
It is. This is one of the rarer types of congenital neutropenia, and I think it was really very insightful of everyone to pick on the superficial vascular markings. That's I've never seen a case, but that's said to be one of the big tip-offs for the diagnosis, and people really got to that very quickly, so very impressive.
Yes.
All right. Thank you so much, Saul and Palmira. Thank you so much. Really interesting case. So many of us will not get a chance to see a case like this. So thank you so much for sharing. I'm going to queue up Barry's presentation, and Sergio will be the co-moderator for that. Give me 1 second to just get it switched over. There we go. So Barry Pelz is from Chicago, and he has a case that also is a little bit of a fooler, And so I urge you to pay attention because the diagnosis will not be so obvious. I'm going to clear the chat, and we're going to get Sergio queued up as moderator. Thank you again to Palmira and Saul and Dutton, and we will let Barry get going.
Good evening, everybody. Can you hear me?
Yep.
My name is Barry Pelz. I'm one of the fellows at Northwestern University in Chicago at the Ann and Robert H. Lurie Children's Hospital of Chicago. I'm very privileged to present one of our cases. It's entitled Gait Abnormality and Infections in a Child. Are we all set to start?
Yep, you're ready to go.
Okay. Two-year-old boy presented to the outpatient immunology clinic for evaluation of a possible immunodeficiency. His history was notable for an eczematous rash that developed at 3 months of age. Soon after the onset of the rash, he and his family moved back to Sri Lanka because of visa issues. While there, he was hospitalized with pneumocystis jirovecii pneumonia at 9 months of age, and he was admitted for 1 month, requiring intubation for the first 2 weeks. During that admission, he was also treated for a scabiatic rash. At 10 months of age, he developed mouth ulcers, and at 11 months of age, he was treated for another skin infection. The mother noted that he had normal growth, but he did not start walking until 14 months of age, and he falls more frequently than his older brother. There is no family history of immunodeficiencies or recurrent infections. The parents are consanguineous. They are second cousins once removed. There is an older brother who is healthy, and mother has had 3 previous miscarriages. Physical exam revealed a boy with height in the 60th percentile, weight in the 35th percentile, and head circumference at less than 5th percentile. He had no lymphadenopathy and no organomegaly. His neurologic exam revealed a wide-based, unsteady gait. The white blood cell count was 9,960 cells per microliter, with a normal neutrophil count of 2,112 and normal lymphocyte count of 7,311. Further immunologic workup yielded normal, if slightly elevated, lymphocyte subsets with CD3 T cells with an absolute count of 5,398, CD4 cells of 3,749, CD8 cells 1,499, NK cells of 206, and CD19 positive B cells of 1,801. Lymphocyte proliferation to antigens revealed normal proliferation in response to Candida, but response to tetanus toxoid antigens did not exceed background. Immunoglobulins were notable for an elevated IgM of 182 with a reference range of 46 to 160 milligrams per deciliter, a low IgG of 183, a nearly absent IgA of less than 6.67, and an undetectable IgE of less than 2. We'll pause here to elicit what people are thinking about in their differential at this time.
So we've got some great comments going. So we've got JJ suggesting ataxia-telangiectasia. We've got Avni coming up with POLI1 deficiency. Luis, again, hot on the skids here.
Okay.
Got a fair number of ATs. I don't know what can means, Joyce, but I'm sure there's another syllable there. I want to just remind people about this microcephaly association with dyskeratosis congenita. You know, I'm big into syndromes, and I think people forget about that. Microcephaly with a small cerebellum, often they will have a little bit of a wide-based gait, a little clumsiness. Dyskeratosis congenita is always something to think about when you're faced with IUGR or microcephaly. So I would put that on the differential as well. Any other ideas that people want to put forward in the chat?
So, Kate, let me interrupt you a minute. So, Barry, one question. Can you analyze the immunoglobulin levels in this patient? There's anything that the age So do you think that at any age, IgA less than 7 is going to be a significant value?
No, I think that at this age, the IgA level being low is probably not all that significant because it's the last one that we would expect the child to start making. But what was more remarkable about the immunoglobulins is just that the IgM is elevated, and then in that context, the other ones appear to be pretty low.
So, and was the IgM kind of hyper-IgM, or was just slightly elevated?
Well, the upper limit of normal in our lab for his age group was 160, and his is just above that at 182.
So it means it's just minimally elevated, right?
Correct.
Good.
Okay, very good. So we'll move on to our main differential diagnosis, which included all of the hyper-IgM syndromes, including CD40 ligand deficiency, CD40 deficiency, and ataxia-telangiectasia. The hyper-IgM syndromes comprise the immunologic phenotype of low IgA, IgG, and IgE with either a normal or an elevated IgM level. The absence of IgG, IgA, and IgE is due to a defect in isotype switching. The IgM level, which can be normal or elevated, is probably elevated secondary to infections. These defects can result from the absence of T-cell help, B-cell signaling defects, defects in isotype switching enzymes, or defects in DNA repair. So first we'll discuss the defects in T-cell help and B-cell signaling. CD40 ligand deficiency, or X-linked hyper-IgM, is the most common form of hyper-IgM syndrome, affecting about 70% of patients. CD40 ligand is a T-cell surface molecule that is required for driving B-cell class switching recombination and T-cell interactions with monocytes and macrophages. Thus, the clinical presentation of patients with CD40 ligand deficiency is that of a combined immunodeficiency. In addition, since CD40 interactions are important in granulopoiesis, neutropenia is a common finding in these patients. Nearly 50% of patients with CD40 ligand deficiency present with pneumocystis urevecii pneumonia and other opportunistic infections, including cryptosporidium and cytomegalovirus, which have also been reported. Hematopoietic stem cell transplant is curative, and PJP prophylaxis and immunoglobulin replacement are often the mainstays of management while awaiting transplant or in those patients who have a milder disease. CD40 deficiency is a rare form of hyper-IgM that is inherited in an autosomal recessive fashion. It presents very similarly to CD40 ligand deficiency. CD40 is present on B cells and on many non-hematopoietic-derived cells. Thus, multiple signaling pathways are affected, including B cell development and proliferation, immunoglobulin class switching, monocyte macrophage maturation and activation, and the signaling through the CD40 TNF receptor-associated factor axis, which activates NF-kappa B. Stem cell transplantation is the best treatment option, but it may be less successful than in those with CD40 ligand deficiency, since many non-hematopoietic-derived cells are also affected. Hyper-IgM syndromes that are associated with ectodermal dysplasia include mutations in the X-linked nuclear factor kappa B essential modulator of protein, or NEMO, and the autosomal dominant defect in I-kappa B alpha protein. Since our patient did not have ectodermal dysplasia, these deficiencies were much less likely on our differential and thus will not be discussed in any further detail. Defects in enzymes required for isotype switching, such as mutations in activation-induced cytidine deaminase, or AID, lead to defective class switch recombination and somatic hypermutation, as this enzyme is required to generate double-stranded DNA breaks. Classically, these patients have lymphoid hyperplasia because defects in AID result in giant germinal centers that have proliferating B cells. Uracil DNA glycosylase deficiency and post-meiotic segregation increase 2, or PMS2 deficiency, are two other disorders which can present similarly to AID mutations. And lastly, DNA repair defects can present with the hyper-IgM phenotype. However, since defects in DNA repair affect more than the hematopoietic cells, they generally have more global effects, as is the case in patients with ataxia-telangiectasia and Niemogen breakage syndrome. Patients with ataxia-telangiectasia have either a non-functional or an absent ATM, or ataxia-telangiectasia mutated protein. The gene for ATM is located on chromosome 11, and the protein is a protein kinase that can activate cell cycle checkpoints and apoptosis in response to double-stranded DNA breaks. The protein also contributes to the stability of DNA double-stranded break complexes during VDJ recombination. Ataxia-telangiectasia is an autosomal recessive disorder that's characterized by abnormal gait, or ataxia, ocular and cutaneous vascular malformations, immunodeficiency, excessive radiosensitivity, and an increased incidence of malignancy. Patients typically have head and trunk swaying early in life. Gait abnormalities typically do not worsen until about 5 to 7 years of age, when the diagnosis of a neurodegenerative disease is often considered. Around this time, telangiectasias typically appear, usually first on the bulbar conjunctiva. Most patients are wheelchair dependent by the end of the first decade of life. Immunodeficiency is not usually an initial feature of AT, although T and B cells are highly susceptible to problematic maturation over time. Most of these patients are lymphopenic, but they have largely intact proliferation to mitogens, and they tolerate live viral vaccines. Immunodeficiency and the neurologic degeneration, which may lead to increased risk of aspiration, make chronic lung disease a very common cause of morbidity and mortality in these patients. Other affected patients may succumb to malignancies, and mainly lymphomas. So for our patient, the primary considerations in light of his elevated IgM, his history of PJP, and his ataxia were CD40 ligand deficiency, CD40 deficiency, and ataxia-telangiectasias. Alpha-fetoprotein levels were normal on 2 different screens. They were 2.1 and 2.7 respectively, with a reference range of 0 to 8.9 nanograms per deciliter. He had a normal CD40 ligand by monoclonal antibody and normal binding to CD40, indicating that a mutation in CD40 ligand was extremely unlikely. He had absent switched memory B cells, which suggested a defect in the CD40 ligand CD40 pathway, and thus CD40 expression was tested. Evaluation of CD40 receptor showed absent expression on B cells, indicating that he had a defect in CD40. The patient was referred to neurology for evaluation of his ataxia, where it was discovered that he was wearing shoes that the mother wanted him to grow into. He actually was switched into more appropriately fitting shoes. He had improvement in his gait instability, but not complete resolution. He was referred to the stem cell transplant team for evaluation of stem cell transplantation, which he underwent successfully and since then has been doing well. Thank you. And with that, I would be happy to hear any questions or field any comments.
Barry, that was a very fun ending to your story. I love the shoes. I'm going to put up a little poll, I think. Does everyone see a poll about AT-like versus AT? Lots of people guessed ataxia-telangiectasia for this case, which, based on the title, I think most of us would have come up with, but I thought we would take a minute to just refresh our memory about AT versus AT-like disease.
So, Barry, can you hear me?
I can hear you.
It was a fantastic presentation. After the poll that we have, I have a couple of questions for you and for the rest of the group in the webinar. So we'll wait until the poll is done.
Well, okay. I couldn't fool anyone. Everyone remembered that the big difference is that there's no telangiectasias in AT-like disease. So good for everyone for remembering it. I have to say, I get it confused sometimes. So good for everyone. I'm going to close out the poll and let Sergio talk.
So Barry, that was a fantastic presentation. Can we go back to the differential diagnosis slide?
Sure. Okay, can you see the differential diagnosis?
Not me. What about the rest of the group?
I have it.
Yes, I do have it here. So Barry, I have to be honest with you. As an NIHer, I feel deeply offended that you didn't include a new form of hyper-IgM that was described at the NIH last year. Do you know what I'm talking about? And if you solve this question, I will not be offended anymore.
PI3 kinase deficiency?
Exactly. Can you discuss about PI3 kinase?
Well, at the time that this patient presented, actually, it hadn't been discovered yet, or it preceded the publication of that paper.
Okay.
But you're right. I think that I should add it to the differential.
Why? Because it's a pretty common form. It's a dominant form of hyper-IgM syndrome. So PI3 kinase or P110 delta, of the two main papers that were described, the first group, the European group, was described in the cohort of hyper-IgM syndrome. And then multiple people have found patients that they have hyper-IgM, as you very clearly said before, you don't need to have hyper-IgM to have a hyper-IgM. I know that doesn't sound very smart, but with having a normal IgM, that's enough. Actually, the hyper-IgM syndromes are usually defined, as you very correctly said, by the low levels of IgG, IgA, and IgE rather than by high levels of IgM. Normal levels of IgM usually suffice in order to diagnose or make somebody to have a hyper-IgM syndrome. But patients with PI3 kinase mutations, they do have hyper-IgM, as which other gene, Barry, come on, impress me, which other phenocopy of PI3 kinase can also present with hyper-IgM? Which is the natural ligand for P110 delta?
Oh, Sergio, we got a quick vote on the chat side.
Oh, yes, David. David is there. So can you see there the chat?
P85.
Exactly. P85, there is the molecule, the regulator molecule that binds to P110 delta is a phenocopy of P110 delta or PI3 kinase or PI3CD. So there you have two other genes that they're autosomal dominant that also could present with hyper-IgM syndrome. But here, Diana has a very good question. What do you think, Barry, about I do not remember the microcephaly, not in PI3 kinase, even here in CD40 ligand. What do you think about the microcephaly in this patient?
So CD40 deficiency has been associated with microcephaly, and it's thought to be related to some cerebellar dysgenesis, but I don't think it's well understood why CD40 deficiency is associated with microcephaly, but perhaps it's because other non-hematopoietic stem cells are affected.
And what do you think about the gait abnormalities beside the shoes? That was a very important issue.
We do think there probably is a little underlying cerebellar dysgenesis, I mean, he had an MRI that was normal, but we think that there probably is some underlying neurologic deficits. But our neurology colleagues, they didn't identify anything specific.
So let me tell you, when I face, at least myself, those patients that they are complex, I just make myself a very easy way of trying to understand them. So patients usually have common diseases with common manifestations, clearly not the case that you presented. Patients can have common diseases with rare manifestations. This is not a common disease, so clearly not your case. They can have rare diseases with common manifestations. Again, CD40 deficiency is not common at all. They can have rare diseases with rare manifestations, and there's where perhaps the microcephaly and the gait abnormality could fail, or they can have new diseases. But I will add another thing. So there was nothing about the family history that suggests that this patient have genetic diseases. First slide. You said that the parents were consanguineous, right?
Correct.
So there's any chance, do you know which is the probability that somebody has two genetic diseases?
I don't know.
Based on your silence, I think that perhaps you was taught, as I was taught in med school, that one disease is usually enough. So people in Baylor have done whole exome sequencing 250 people, and they found that 1.5 of the patients, the 250, they have two genetic diseases at the same time. And if they just analyze the patients where they found one disease, 6% of the people, they have two completely different genetic diseases. So I think that your patient is going to be a very good candidate to see if, besides the CD40 ligand, he had another disease. Because CD40 ligand, there are very few patients. But you know, your patient exceeds what we usually expect to see in patients in CD40. So already has one rare disease, but it has rare manifestations in a rare disease. Now, based on what we learned from the Baylor team, we have to change the way we were taught to think and think that people might have more than one genetic disease. So which kind of genetic analysis did you do in your patient? So was the mutation
CD40? You mean general?
No, I mean the CD40 mutation.
Yeah, we did CD40 sequencing.
Okay, and would you think that after what the Baylor team suggested, that people that have a lot of bad luck, they might have two genetic diseases? Which kind of approach do you think that you should follow, especially in a family that's very strongly consanguineous?
Probably needs a broader workup, like a mic.
Like a?
Like whole exome sequencing.
Exactly. Like Joyce is saying, I absolutely agree. Because this patient, so it has a very rare disease, not that rare when you are, a carrier of a mutation and then you marry your cousin, that increases the chances of that disease to present. But in this case, has very rare manifestations as a very rare disease. So I will not be that surprised if this patient happened to have a CD40 deficiency plus something else. So I think that this guy is going to be a great candidate to look for the CD40 that you already confirmed. And actually, as most of the people here now are suggesting, like Luis, Joyce, and Abney, so Abney, because he's rich, he's suggesting a trio, and he's right. Trios for whole exome usually give us an increased chance to get some mutations, but not that much. So keep in mind that if you analyze the patient, you will get it right in 15 to 25%, and if you do trios, you will increase by 7-8% the chances of getting a mutation. So I think that clearly your patient has a mutation in CD40, as you already found, but there is a chance that might have something else.
And Sergio, I think that makes a great point. I like to pair if I have unlimited money, which definitely is not always the case, but in those rare circumstances where I have unlimited money, I like to pair my whole exome sequencing with copy number analysis because of the importance of ruling out deletions on the alternate allele. So I like to pair them when I can, and I think it's a really valuable approach, but I appreciate that it's not financially feasible in all cases.
Absolutely. And does everybody know why people want to have copy number variations? Which information that provide us the copy number variations? So do it by chat. If anybody has an answer, just answer by chat. Exactly, as John suggested, John Leonardo Blasi, exactly where you're looking is for big deletions of pieces of DNA. So you look to have an homozygous mutation, and actually what you're looking is an hemizygous, that you're looking just a single allele because the other allele doesn't exist. So that's when a copy number variation test is going to help you to discriminate between homozygous and hemizygosity, among many other things. So that was fantastic, Barry. If you want, we can talk and we can negotiate later about whole exome sequencing your patient.
Okay, thank you very much.
You are very welcome.
So I'd like to just take a couple moments to thank both of our presenters, Palmira and Barry. I'd like to also thank the two guest moderators, Dutton and Sergio. And Jesse is reminding us that these presentations are cached on the CIS website. So if you ever want to go back and review them, they will be there. The other thing, I have a couple of tiny announcements before we finish up. This is the last one of this academic year. We're going to take the summer off. So Joyce Yu and I have been organizing these webinars. We're going to take the summer off and then restart in September. So look for the announcements again starting in September. If anyone on this webinar would like to present a case, please let me know. I'm always looking for good cases and good presenters, so don't hesitate to recommend yourself if you have an interesting case. I'd love to hear from you. And with that, I think Joyce and I would both like to say thank you so much for your contributions and for your participation. These case webinars are really a lot of fun, and I hope you enjoy them. Special hello and goodbye to the people that joined from South Africa and from Saudi Arabia. We always love the long-distance participants. I don't know how you do it, but we're always happy to hear from you. And thanks to everyone on the webinar tonight. Your participation was great. And with that, bye-bye.